So what we're going to talk about right now is the auditory nerve and the central auditory pathway. So we've moved beyond the cochlea. We're now in the central auditory system as opposed to the peripheral. So the outer and the middle and the inner ear were considered peripheral. The auditory nerve and the central auditory system, the auditory cortex, are the central portion of the system. So remember, sound is only meaningful if it is perceived. Therefore, the brain is essential. You could have a healthy outer ear, a healthy middle ear, inner ear, a healthy auditory nerve, but at the end of the day, if the brain isn't pulling it all together and making sense out of it, you're really not getting any meaning out of these sounds that are out there. And we still know very little about the nervous system. So we know very little about the brain and how things work. We very little about how it transmits sounds, how it receives sounds, how it processes sound. The reason is because, we can't really do studies on awake, healthy, alive people and their brains. You're not going to donate your brain to a medical study right now. So most of the research that we have on how the brain works consists of putting a bunch of electrodes on someone's head and measuring the electrical activity of the brain. So still much to be learned about the brain. The auditory nerve and the central auditory pathway are very complex. You have ascending afferent nerve fibers and you have descending efferent nerve fibers. So afferent nerve fibers send messages up through the cochlea to the brain. All afferent nerve fibers send messages up to the brain, and efferent nerve fibers send messages down and out. For example, if you were to hold your hand over a fire, your afferent system would send the message up to your brain that it was hot and you were being burnt. The descending efferent fibers would come down and remove your hand. When I was in graduate school, my friend I went to St. John's, my friend would take the E-train home. So he said that he remembers the efferent fibers as the way out because the E-train was his way home. Get it? So his E-train was his exit from St. John's. The efferent fibers head down and out. The afferent fibers head back up. And we have afferent fibers for both ears of the head, and we have efferent fibers on both sides of the cochlea. So the way your auditory system works is there's a series of way stations that perform complex processes. So you've got groups of nerves all along your auditory cortex and all along your brain. And what they do is they process sound and they share sound and they process and they share and they process and they share all the way up. So they're deciphering the message, they're processing the message, they're sharing the message with both sides. So the messages go up, over, up, all the way to your auditory cortex. So there are a lot of nerve fibers and there's a lot of analysis and reanalysis of the acoustic message, and that's called intrinsic redundancy. So the fact that you have these groups of nerves going up, sharing information, processing information, and sharing and reprocessing, that's called intrinsic redundancy. And we think that all of the intrinsic redundancy in the auditory system helps us better hear the message, and it kind of like separates the message from background noise and just makes the message clearer. And we wonder if people who have trouble hearing speech and noise lack intrinsic redundancy. So maybe people that have auditory processing disorders, they don't have enough intrinsic redundancy in their auditory cortex to fully pull the speech sound out from the noise. Any disorder of the auditory nerve is a sensory neural hearing loss. So now we're in the neural part of it. Common symptoms of auditory nerve disorders include tinnitus, that's the ringing of the ear, a high-frequency hearing loss. It could be unilateral or bilateral. For example, an asymmetrical hearing loss. So having a hearing loss in the left ear and not the right ear, that's a sign of an auditory nerve disorder. Asymmetrical hearing losses, a hearing loss in one ear and not the other ear, or two very different hearing losses. and the discrepancy between the amount of hearing loss and the scores on speech recognition tests. For example, doing fairly well on an audiogram but having terrible speech recognition scores. So those are symptoms of auditory nerve disorders. A cause of an auditory nerve disorder could be a lesion on the 8th auditory nerve, which may result from disease, irritation, or pressure on the nerve trunk. Etiologies include tumors, meningitis, a hemorrhage, or a head trauma. There are tumors on the auditory nerve. Most of them are benign. They could vary in size. They arise from the sheaths that cover the vestibular branch of the 8th auditory nerve on the peripheral cells, and they're called an acoustic neuroma. So a growth, a neuroma on the auditory nerve would be considered an acoustic neuroma. They're usually benign. They vary in size. So they could be very small, and they could not affect hearing, and they could not cause any other problems, and you may just want to leave them alone. But they might also grow large, and if they grow large, there's a greater probability that they're going to put pressure changes on the cochlea, the vestibular system, or the facial nerve, in which case you might want to consider removing them. About 1 in 100,000 people develop acoustic neuromas. They're more common in adults over the age of 30. They're usually unilateral. So remember I said a sign of an auditory nerve pathology would be a unilateral hearing loss. Usually the tumor would occur on one side and not the other. They might be caused by the absence of a tumor suppressor gene. The earlier they are discovered, the more successful the chance of removal is, the easier it is to remove it without doing major brain surgery. As a tumor increases in size, the symptoms will probably become more obvious, including tinnitus, which is the ear ringing, dizziness if it pushes on your vestibular system, a hearing loss if it pushes on your cochlea, and speech recognition difficulties. So remember, another symptom would be rather normal hearing and poor speech recognition scores. The symptoms may become progressive, so they get worse over time. If the tumor grows and starts pushing on the facial nerve, the 7th facial nerve, then you would have facial weakness or numbness. You might have alterations in your senses of taste and vision with the 7th facial nerve if it becomes affected by the size of the tumor. Like I said, these tumors are usually benign, but as they grow, they may do damage by pressing on the brain or other cranial nerves. And the decision on whether to operate and remove the tumor depends on the age of the individual, how long the tumor's been growing, if it's only been a year, if it's been 10 years, the size and the location, the patient's preference, and the symptomatology. So probably like 10 years ago when I first started teaching, I had a student and she came up to me after class and she shared that she had an acoustic neuroma that it was just discovered, but she was young. She was probably in her mid-20s and she was healthy and the tumor was benign, and I believe her father had just died of brain cancer or brain tumor. So she didn't want to put her family through going through a surgery and everything else. So she decided that she was going to hold off and just have the tiny benign tumor be monitored. Now there's technology. Maybe she went ahead and did the gamma knife. So a gamma knife is a focused beam of gamma radiation to stop the tumor's growth. There's no surgical incision necessary, therefore you don't have to worry about infection. So remember, surgery, anything near the brain can be very serious. So to do a surgery on the brain or near the brain, it's scary stuff. A gamma knife is a focused beam of radiation to just sort of kill the growing tumor. This is an outpatient procedure. It minimizes the damage to the surrounding tissue, and it's painless. Acoustic neuromas, as they grow, are associated with gradual and progressive hearing loss. Like I said, it depends on where the tumor is and the size of it and whether or not it interferes with the blood supply of the cochlea. If it interferes with the blood supply of the cochlea, then you're going to have damage to the cochlea and you're going to have hearing loss. So the blood provides oxygen to the cochlea. If it gets in the way of that, you have hearing loss. Other nerves might also be affected by the tumor, including nerve 5, where you'd have pain and numbness to the face, nerve 6, double vision, nerve 7, the facial nerve, alterations in taste, facial weakness, the loss of the ipsilateral or contralateral acoustic reflex. Acoustic neuromas cannot be diagnosed solely on the basis of the audiogram. That's why we have an audiological test battery, which includes acoustic reflexes, ABR latencies, OAEs, and speech recognition scores. So a person with an acoustic neuroma will have otoacoustic, their audiogram would display sensorineural hearing loss. They probably would have very poor speech recognition scores. Their OAEs would be present. Their ABR would show delayed latencies, and their acoustic reflexes, depending on the size and the location of the tumor, might be absent. There are also vestibular tests, so spontaneous nystagmus, that's when your eyes go back and forth when the eyes are closed. Decreased vestibular function on the side that is affected by the tumor, and an increased amount of protein in the fluid. ABRs are a way, so often these tumors would be diagnosed in an audiologist's office and confirmed in a doctor's office with an MRI. So you're not going to go ahead and do any sort of gamma knife radiation without an MRI. But the first diagnosis usually comes with delayed ABR waves found in an audiologist's office. Another disorder of the auditory nerve or the central auditory pathway was auditory neuropathy, also known as auditory dyssynchrony. So this occurs in patients that have normal outer hair cell function, but the responses on the 8th cranial nerve that carries the electrical signals to the brain fail to synchronize. So remember I said that as sounds go up your auditory system, there's processing and reprocessing and sharing. Something is wrong in individuals with this disorder in that their groups of neurons aren't syncing up. They're not syncing together to process the sound. So instead of a smooth transition of information from the cochlea to the brainstem, the information is not relayed in a consistent manner. It is dysynchronous. The degree of dysynchrony can vary from person to person, and what's interesting about this disorder is that it can fluctuate within the same person. So for a period of time, the hearing might be rather normal, and then for another period of time, it might be abnormal. Persons could have a mild to moderate sensorineural hearing loss, again with very poor speech recognition scores, the absence of all the ABR waves, but no evidence of lesion on the 8th auditory nerve or the brainstem. So the MRI would be normal, but you would have no ABR waves. You'd have OAEs and normal cochlear function. The hearing loss could appear slowly, progressive. These people often do not demonstrate any benefit from hearing aids. Okay, so it's a problem with the processing of sound up the auditory nerve to the auditory cortex. It's dysynchronous. For some reason, you know what is helpful with some of these patients? Cochlear implantation. So if you remember, well, we'll speak about it more in the coming chapter, but cochlear implantation is electrical stimulation of the cochlea. So the outer hair cells are kind of skipped over, and the auditory nerve is directly electrically stimulated. And something about the electrical impulses tend to help the auditory system in people with auditory neuropathy and auditory dyssynchrony sync up. So the electrical impulses helps the auditory system to sync better. and cochlear implantation is a treatment for people with auditory neuropathy and auditory dyssynchrony. Another disorder of the central system would be auditory processing disorder. So, auditory processing disorder is when the person has normal hearing, normal audiograms, normal hearing, normal OEEs, normal ABRs, but there's something happening where the child or the adult is having trouble focusing. They're having trouble concentrating, especially in speech and noise. Auditory processing disorder is difficult to interpret. So it's a difficulty in interpreting auditory information with normal hearing, though. So further difficulties are compounded by auditory and visual distractions. This is a bit controversial. Some people believe very strongly in auditory processing disorders, and others say, no, it's not auditory processing disorder, it's ADHD, or it's specific language impairment, or it's the learning disability. So the way I talk about it is, the way I think about it is, there's a lot going on in the brain, and it takes a lot for the brain to fully understand, process, and respond appropriately to incoming stimuli. And I think that there isn't necessarily a specific diagnosis for everything. It may be it's speech language disorder, a specific language impairment. Maybe it is a learning disability. Maybe it's a reading disability. Maybe it's auditory. The issue is that there's the child needs support. So the child needs help. The child needs extra time. The child needs preferential seating. The child needs other services to help them succeed. Regardless of who diagnoses it or how you treat it, the child just needs extra help and extra support to succeed. Now, there's also auditory processing disorders that could occur later in life due to cardiovascular anomalies, head traumas, brain tumor, multiple sclerosis. And for people that have auditory processing difficulties from later in life, like a stroke, they have a less of a chance of recovery than the pediatric population, because the pediatric system is much more adaptive and it's easier for young children to learn compensatory strategies. Symptoms of auditory processing disorder include increased distractibility, trouble with auditory discrimination and localization. Localization is knowing where sound is coming from, and difficulties comprehending speech, especially in noisy situations. So the hallmark of auditory processing disorder is a person has trouble understanding speech in a noisy situation. Another disorder which is somewhat controversial is the minimal auditory deficiency syndrome. And this would be a change in the structure of the brain as a result of cochlear conductive hearing loss. So for example, if an infant has numerous ear infections in the first 3 years of life, what does that do for the child later on? So if you have a number of ear infections when you're learning language, when you're in that critical period of development, you might have mild hearing loss one day, you might have a moderate hearing loss another week, then you might have normal hearing, you might have unilateral hearing loss for a period of time, or a bilateral hearing loss, or again, normal hearing. So with someone that has this disorder, the question is, what are the long-term effects of these hearing losses that are coming and going and mild or moderate, and is there a long-term effect? So how does these ear infections affect the development of the essential skills for learning language? And this is somewhat controversial. Some people say that there are lasting effects. Others say, no, there aren't lasting effects, that the brain, isn't reorganized by these ear infections, and that the language catches up. So like I said, some people believe in it, some don't. I believe in this. I think if you have a number of severe ear infections over a period of years, there is going to be a long-term effect on the brain development. Going back to auditory processing disorder, it's tested using the scan. The scan, it's a hard test. It's a series of different audiological tests where the child's asked to say different things, combine words, listen to words and noise. It's a challenging test, and it's not the best, it's what we have right now. One of the reasons that auditory processing disorder is controversial is that there is no objective test. And there's no objective test of specific language impairment. There's no objective test of ADHD. When I say objective test, I mean you can't take a blood test and say, oh, the person has APD, or take a blood test and say, oh, this person has dyslexia. We just have subjective tests where the person or the child sits through a series of tests that are scored and, say, compared to norms, or it's based on the clinician's opinion. So again, without an objective test, some of these things remain controversial. If you have auditory processing disorder, these are all going to be normal: tympanometry, reflexes, ABR. It's diagnosed with a team, and I think you should work with a team. So audiologists, or work with speech-language pathologists, with educational psychologists, with a teacher, with reading specialists. What's really happening in my mind is there's a lot going on in the brain. The diagnosis doesn't necessarily matter, the name of the diagnosis, just as long as the child gets the support that he or she needs.